Thank you very much. That's fantastic. Can I just thank Pete and Olivia for putting on a fantastic program? This has been really brilliant. Right, so we thought we'd end on a high note and talk about neurodegeneration. So I think it goes without saying, neurodegeneration is a big problem, but it helps to put this in context. So it's estimated that currently today, there are 60 million people in the world living with dementia. And that number is projected to triple within 25 years. Yeah, and in the United Kingdom alone, it is estimated that about 1 in 3 people alive today will be affected by dementia in their lifetime. So these figures, these numbers are simply unaffordable. Yeah, they will break most countries' economies. And so it requires us to fundamentally change and shift how we diagnose, manage, and treat these disorders. Now, it's not all doom and gloom. There are some properties of these illnesses that we can take to our advantage. And this is one of them, is that by the time we clinically diagnose people at the moment, they've already lost substantial amounts of brain tissue, and the disorder has been present for anywhere up to 10 to 20 years. If we could push the boat out and identify people at a much earlier stage, then we would only need a modestly effective treatment delivered much earlier for you to outlive your condition and enjoy many more years of quality of life. And when we're talking about these illnesses, so neurodegeneration is just any disease that causes faster cell loss than you would expect to get with normal healthy aging. The most common is Alzheimer's disease, followed by Parkinson's. And I'm going to spend the remainder of this talk largely focused on Parkinson's and related disorders, really because there are several properties of these conditions that really speak to some of the advanced quantitative imaging that Chris and Nick nicely introduced earlier. So MRI in Parkinson's. It's one of my firm beliefs that in neurodegeneration, one of the key properties of MRI is it should be able to capture and recapitulate the histological hallmarks of disease. And we know that it can do this. So in Alzheimer's disease, it's been very successful. You don't need many subjects to show the anterior medial temporal tissue loss. In Parkinson's, we know for you to have motor symptoms, you must have significant loss of dopamine-producing cells in the substantia nigra, in the order of 60 to 70% of the cell loss. And yet when we do very large meta-analyses in this disorder, what we repeatedly find, all the way through to very large numbers, so this is 1,000 subjects meta-analysis, is this finding is absent. And this speaks to a significant problem with the techniques that we're using, and it all comes back to the conventional MRI methods, namely T1 weighted MRI, cannot visualize or see these areas of the brain. And this becomes a problem in terms of the way we analyze anatomical data. And so fundamentally what we're trying to do is line up like-for-like brain regions and then use SPM to analyze this data and identify significant regions. And the problem with the brain stem and other deep brain structures is using the standard processing pipelines, we simply don't have the contrast. So on the far side there, we have the output of free surface, which gives you 3 tissue classes, and SPM, which largely gets lumped into white matter. And so using that approach, you can then start to appreciate why these findings are invisible using these sorts of approaches with T1 weighted MRI. So for the remainder of this talk, I'm going to be discussing methods that exclusively use the multiple parametric mapping techniques that give us quantitative magnetization transfer, proton density, R2 star and R1 data. And it's all been processed through using the histological MRI toolbox to generate those maps. And so my journey in this started during my PhD with John, way back in the day, where we used the magnetization transfer and proton density images together to generate new tissue probability maps for SPM. And it was the variation in both signals that allowed us to identify these boundaries. And we could generate the new probability maps and then overlay them onto a histological atlas and see that actually what we were getting was very closely aligned to what we would expect to see with the histological data. We could then embed those methods within the classic SPM anatomical framework. So a lot of methods that I do nowadays involves you do a first pass segmentation to generate your first population average template. You then take your new probability maps and use those to resegment your data into an increased number of tissue classes, and then realign everything again using the nonlinear warping. Nowadays we use shoot. And what you can appreciate from the Jacobian determinant data is at the top, you've got your standard imaging where you've got no real estimation of what's going on, say in the middle of the ponds there. It looks like someone's smoothed a pencil drawing. Whereas at the bottom, you suddenly have all this rich data telling you how much expansion or contraction has gone on at an individual voxel level. We applied this to Parkinson's disease. So we know that at a group level, we can recreate these hallmarks of disease. So on the top row, I've shown a slice through the midbrain that shows that this very focal substantia nigra atrophy using very low levels of smoothing. And on the bottom, because it was multiple parametric mapping data, we also had access to R2 star, which gives us a surrogate of iron levels. And we get this very focal increase in iron in the posterior lateral tip, which is well recognized. We can then take the same approaches and use them for, say, classification. So combining different channels of data, we can now use it to categorize Parkinson's from controls with a level that approaches the dopamine transporter scanning, which is the current clinical standard of care. So that's what is used in the NHS at the moment. We can also feature select and ask the question, well, what areas of the brain are driving these predictions? And unsurprisingly, get back to both the substantia nigra, but also what starts to pop out is the locus coeruleus, which is another key structure in the development of Parkinson's. This is all group level, but we've now taken this a little bit further and we can start making inferences at an individual subject level. So this is looking at the difference between your predicted and actual substantia nigra volumes, correcting for obvious confounds. What we can see at the top is a healthy controller here, age 64. The very bottom here, we have someone with young onset Parkinson's, age 49. They're a year from their diagnosis. And the nice thing about neurology is we have localization. So this young person had left worse than right-sided disease. And on the brain maps that we get right worse than left-sided nigral atrophy. In the middle two, we have a condition called REM sleep behavior disorder. So this is a high-risk condition for developing future Parkinson's. Around about 90% of people will develop a condition over a 20 or 30-year period. What we can see when I first met them is that clearly the nigral maps were normal, but clinically there was nothing really to find. And then a couple of years later, this person has started to develop an asymmetric answering on the right, bit of stiffness on the right, to the extent that his clinical neurologist did the DAT scan. His DAT scan is currently normal, but we can clearly appreciate that there is this volume loss of the nigra. And so we're now testing this against DAT scans in the NHS setting with some funding from the Hillary and Galen Weston Foundation. We can take this idea one stage further. So a lot of this work initially was just focused on brainstem and brainstem related imaging, but we can use the same trick with generating new probability maps from the MPM data and apply it to the whole brain, which is something that we've done. What I'm going to do is introduce these methods and show an application of this that we've just finished actually, which uses 8 tissue classes now. There's brainstem and cortical, and we separate them out. It focuses in on a disease called multiple systems atrophy. So MSA is like Parkinson's disease, but it's highly aggressive. So average survival is around about 7 years, and it's characterized by both Parkinson's and profound autonomic failure. Like Parkinson's disease, it is a brainstem-centered disease. So whilst there are slightly different types, it's unified by they must have Parkinsonism, they must have nigral atrophy. And we know, again, using the same trick, looking at a meta-analysis, that this is a finding that is repeatedly absent using the traditional literature. So just to give a little bit of an insight on the methods here, so we're using 8 tissue classes, we're using the MPM data, and the results I'm going to show is going to compare the standard VBM approach with 3 tissue classes versus one where we've used this optimized approach. We've done 2 millimeters of spatial smoothing. Everything survives family-wise error correction, but I've shown it between 0.001 uncorrected and family-wise error. So this is what you'd get with traditional VBM. If this was your results, you'd be very happy with that. It shows that you've got some cerebellar atrophy. These people often get a bit of ataxia, and its involvement of the basal ganglia structures. And you can almost convince yourself that maybe there's some nigra, but they also get atrophy of the cerebellar fibers, so difficult to tell. When we drive down the spatial smoothing, we actually increase our spatial sensitivity to a significant amount, and our effect size increases substantially. We're now starting to see very precise structures that align with the histology of this disease coming from staging. So we've got our medullary raphe serotonergic nuclei and dorsal motor nucleus of the vagus. We have our locus coeruleus here on the edge of the superior cerebellar peduncle. Of course, we've got our substantia nigra and cerebellar thalamic tract. That's the medial dorsal nucleus of the thalamus and pulvinar. And interestingly, you've got this area here in the primary motor cortex. So all of the other regions up until that one I was expecting to see. I know about MSA, I know where the findings should be, but the motor cortex was a bit surprising to me. But of course, we go off to the literature. Quick Google will find this histopath study from the 90s, which highlights that primary motor cortex is indeed affected by MSA. So again, confirmation in histology of what we're seeing with MR. Just to get a sense again of what the technique's doing. So what you're essentially doing by using and leveraging this data is just really boosting both your effect size in terms of the findings you detect and your ability to be very spatially precise about what you're seeing. Because this study was done using the NPM data, we can analyze all of our other parameter maps. So what we find is, here's the magnetization transfer data, which shows that you've got a profound loss of myelin in the cerebellum. These individuals had more the cerebellar type of the disease, so unsurprising. R1 is a bit of a mixed picture, whereas as is proton density. R2 star, you get quite focal increases in iron in both the striatum and in the substantia nigra. Interestingly, you're getting decreases in iron within the cerebellum, but iron co-localizes with oligodendrocytes is probably more related to that. And then with the quantitative susceptibility mapping, again, you get some distributed changes that partly align with what we find with the R2 star. Importantly, all of these methods that I've presented are embedded and based on the SPM method. It's built off using the classic pipelines and then just iteratively changes, updates, and increases what we can do with that and embeds it all back into the SPM-based analysis method. So, in conclusion, hopefully I've shown that it is possible to map neurodegenerative damage in vivo that aligns with our known histology, and that these techniques can be used to boost both group analysis and also allow single subject inferences. In terms of future directions for these methods, and so it's a fantastic discussion on the microstructural table over there, which tapped into a lot of these. The things we would like to see and work on is improved biophysical modeling to be able to understand what our signals mean at the level of biology, the advances that ultra-high field MRI can offer in terms of increased signal and resolution, improving our anatomical mapping techniques. There's also work going on with multi-scale modeling, so trying to tie down what we see with quantitative MRI to other modalities, such as using induced pluripotent stem cell models in the same individuals. And we have Arthur Mitchell, who's got a poster here, who was presenting some of the early work with that. And then generating increased precisions in our QMRI parameters to enable them to provide sensitive biomarkers. And ultimately, we want these to translate. We want tools to allow earlier, more accurate diagnosis. We want to better subtype disease on a mechanistic level and have ways to measure progression even when we can't see any physical signs. It's a whistle-stop tour through the work that I've done. It requires an army of people to help support. A lot of the clinical data could not be done both without our volunteers freely donating their time and also with the research assistants who've worked on the project over time, currently led by Charlotte Dorr. The project at the moment that we are leading with this represents over 4,000 hours of in-person testing. We are now nearing 500 participants. It's been a long journey. And I'd like to thank everyone else on this slide, and apologies for those who are not mentioned. Thank you.